My background is primarily in healthcare policy and communications.
All right, can y'all hear us okay? That's a good point. Cassie, maybe you can hear us.
Yeah, I can hear you good.
Yes.
Well, no problem there. You can go ahead and advance a little bit more here as we get into the content on this slide. We're going to be going over a couple of things, obviously, from the description of the event itself. You can see that we're going to be going over how to engage your community on major issues related to Medicare Advantage. The first thing we're going to really hit on is identifying, the overall issues of Medicare Advantage, obviously intended as a feature of beyond traditional Medicare, but we also want to make sure that we're laying out some of those issues. So we'll spend a little bit of time going into that, and then going into how to create that educational program. In advance there. So up here in case there's any.
I think we want to start with the assumption that you all know the challenges that you're having in your communities with Medicare Advantage being such a dominant player. And so we're starting from the assumption that you know the challenges. So our objective is to help you communicate those challenges to the various people in your communities that include, as listed there under column 2, the Medicare eligible population themselves, and then also influencers who make decisions about healthcare financing and arrangements.
So that's an important distinction there, is when we're building a campaign, we don't have any one audience in mind. We have multiple, and they all have multiple needs and multiple issues. That can get a little bit difficult and complex unless you have a well-run organization kind of underlying it all. And so we're going to show you how this campaign works and how we develop that to run efficiently, especially because, as I always say, you're running hospitals. Not all the time does this feel like the wolf at the door that you have to answer to every single day. And so sometimes these important things, as important as they are, still get pushed to the wayside because you have other critical situations to take on. Cassie, if you can go ahead and advance again. Our third area, of course, is then identifying those stakeholders, because not only are you going to want to put that message out and engage this audience, but more importantly, you're going to want to have others who are able to perpetuate your message, who are part of your trusted community of voices. So that's going to include a lot of different folks. More importantly, though, it's starting with those in your medical community, right in your own building, and then kind of moving out from there. And we'll go to step 4 here. And then we'll talk about how you mobilize that campaign, minimize costs, target into hyper-local with digital channels, and still use traditional media outlets, but again, doing so in a cost-effective way. And we can go to the next slide. So let's dig in a little bit here into the issues themselves. There's going to be a lot of clicking forward here, Cassidy. So if you can go ahead and move it on. Again, intended Medicare Advantage features and benefits was to incentivize commercial health plans to provide additional features not offered by traditional Medicare.
I think it was also intended to originally, at least theoretically, save the Medicare trust fund. I think there was a notion that, Medicare fee-for-service, traditional Medicare was running completely, wild and unfettered, and driving up costs that was making the Medicare trust fund unsustainable. In the 25 years that Medicare Advantage has been in place, though, I think we've seen that it has not realized its intended features and benefits. And that in fact, it is now kind of running amok and unchecked.
So, and you'll see the perceived popularity based on adoption. We're going to go ahead as we move forward here and give you a little bit of insight on that as that growth has gone on. You can keep on clicking forward here. It'll automatically move forward. But we've got currently enrolled in Medicare Advantage plans about 30.8 million nationwide. Now, we're going to dig down into that a little bit, but understand that that growth just from 2022 to 2023 has been about 8%. That's 2.3 million. And then on top of that, you've got projected growth nationwide that's looking at another 19 million. Again, we've got just the tip of the spear when it's come to the baby boomers joining, the enrolling rather.
And we don't share all this and out of any assumption that this isn't stuff that you don't already know. We know that you live this daily. We share this because it's even more important that hospitals take up the mantle of communicating the disadvantages of Medicare Advantage, because we are up against such a gigantic empirical and demographic mountain.
So again, just kind of, again, arming you with a little bit of what we're all up against, but it's also not great for patients when you consider the overall complexity. So the average beneficiary has about 43 plans to choose from, again, across the board, no matter where they are in the country. They have about 27 plans to choose from if they're in a rural area. Can advance, please. And then, you know, obviously for our hospitals and the patients themselves, I think we got some other facts there if you click forward. You've got the financial side of this. So I know many of you have already experienced this. So this is, again, a little bit of preaching to the choir, but in some cases, it's not just the denials and the inefficiency of denials, but the actual reimbursement rate that's less than traditional Medicare for the exact same services.
And if you're a critical access hospital, obviously you have a second set of challenges layered on top of all those that are listed there. And again, we're only sharing this as things that need to be communicated. While you live this and breathe this and know this really intimately and deeply, there is a general assumption that Medicare Advantage is just an option and that it is on par with traditional Medicare, both from the hospitals and providers perspective and from an enrollee's perspective. And that's the narrative that we need to disrupt.
Right. Next, we're going in to talk about how that kind of works in your community as well. Sorry about that. We've got a repeat slide there. And then the patients themselves obviously have those limitations. So you know, from a provider who's trying to explain to that, trying to get a rehab in some cases, in post-discharge, and to other cases that's much more significant in acute situations. For the local community, when those individuals can't get that care, we're talking about a quality situation. So your outcomes are poor, and the patients ultimately are going to suffer, which doesn't exactly fulfill the mission for your providers.
What we hear most frequently is the inability to get swing bed services covered. And I think that's a particular challenge for rural hospitals to communicate about, because it uses a very technical healthcare policy and payment term for a service that people don't understand, but that is vital to helping a patient transition from, you know, acute inpatient to either post-acute facility or home. And so when those patients, and again, you know this very well more than we do, when those patients can't get that swing bed service, when they're either sent home with home health or they're lost to the urban hospital, those have significant patient care impacts. And that's the kind of stuff that we need to start talking about that makes Medicare Advantage not the best option.
We're going to go ahead and talk about section 2 here, if you could advance one. So let's talk about that audience a little bit. Obviously, we're talking about that Medicare eligible population, caretakers, friends, family. If you could advance to the next slide, we'll dig a little bit deeper. And so before we do that, though, let's again talk about how rapidly this market is growing, and how, as they age, they're going to be depending on others for that information. Again, just a few points in there about this growth, but let's go ahead and advance just in the interest of time. I think it's advanced one more there. All right, so as we get our Medicare population, you have those who are currently eligible. In some cases, those patients have already moved into a Medicare Advantage plan, which is going to be problematic in them trying to move back. So we're really wanting them to get into get to this population well in advance of them making decisions. So you're really talking about those who are not only experiencing trouble with Medicare Advantage and then navigating transition to traditional Medicare, but more importantly, I think the ones we're really focused on some of this messaging is going to be those who are soon to be eligible, or those who are, again, caring for others who are soon to be eligible.
I think ideally, we would love for nobody to ever choose a Medicare Advantage plan. I think getting people to switch and the challenges that come from switching from MA to traditional Medicare is so hard. It would be an ideal world if we could get all, soon to be 65-year-olds just choosing traditional Medicare from the start.
Again, that's where we are, from our, and I know many of you probably agree with that as well. There are some folks that might be in different areas that are serviced by Medicare Advantage just fine. I think you can see the juxtaposition of how that doesn't totally pan out anymore, even in urban areas, as more and more hospitals start abandoning their Medicare Advantage relationships. But nonetheless, we're really talking about education. So while we're focusing in on the pitfalls and how to help people identify moving away or opening up their aperture beyond Medicare Advantage, we nonetheless want to kind of convey a lot of what we're going about and how to educate your community. And again, that leads us right into our influencer population, because many of them can be caregivers they're dependent on as family members and friends who may be, they're in business, and so they're trusted by their mother or father who's entering that Medicare age, and they want to ask some questions. And so that their friends and family do some of the research and Googling around for them. And so they're really critical to make sure that you're reaching as well. So it's, again, not just a senior population that we're trying to target. In addition to that, it's those community leaders as well. And then we'll talk a little bit about the why on the elected leaders, but some of those local leaders are important because now we're talking about the impact that it's having on your hospital. We're talking about the impact that it's having on the financials of the hospital, and whether you are a part of a taxing authority as a hospital district or not. Really, trust in a well-run healthcare system locally is really paramount now more than ever, coming off of a long-term pandemic where there is some distrust. So wanting to show to even a local county officials who aren't part of, who may not have any sort of governing oversight or any involvement with your hospital district, or that you don't have one at all, having them as a voice that understands your responsibility and your stewardship is critical. Same thing with your congressional delegation. More and more, we're getting a lot of positive response from members of Congress who understand the challenges that you're facing. In one particular case, there was feedback from some congressional staff that they want to deal with this. It's just not going to happen between now and November. So, and I think that you can kind of draw those lines there or connect those dots there. The local media is the other part of this. Now, again, no matter how small your town is, if you're in a weekly newspaper market, no newspaper market, and just a bunch of bloggers, figuring out how to engage those people who do have a little bit of broadcast power is critical. And again, if nothing else, then it shows that you are making an attempt to engage, to be A, transparent, B, a good steward to your community. And when you make that connection, whether they're a good relationship, no relationship, or a bad one, that effort to connect and broadcast your perspective, not just out of your own financial solvency, but also, again, because of the care that you're aiming to provide patients. A lot of times, these media, the media folks, especially in local small towns, they don't see the administrators with the same set of eyes that they see and judge maybe a white coat provider from physicians and then all the way to nurses. And so showing them that you have that same level of care and commitment to your patients is a big deal for them, and it can be a real disruptor in their perception of the hospital.
So I think, to kind of sum up on the audiences, so you're communicating to individual patients, consumers, whether they are already Medicare eligible or soon to be. That's an educational role that hospitals can fill. You're trying to educate your community members on the potential for Medicare Advantage not meeting their care needs down the line, and here's how. And then you're going to communicate on the more kind of the policy side with the delegation, with the county, with local media on how Medicare Advantage has destabilized your hospital's finances and operations. And Medicare Advantage, unfortunately, is never going to go away entirely. It's very unlikely that Congress is going to say, you know what, we totally are going to strip this program entirely out of the Medicare system. But you can communicate the impacts, the perhaps unintended or unforeseen consequences of decades of Medicare Advantage, and then propose how you would fix it. So it's not just a matter of, complaint after complaint. It's going through delegation and saying, here's the impact that we've seen of having to deal with these plans, and here's what we need to fix it. And then you're going to talk to your community about, as you make a decision about coverage, in your retirement years, here's things to consider.
All right, we'll get into that messaging structure here in just 1 second. If we could go ahead and advance. All right, so those stakeholders again, let's go into that a little bit and go on to the next slide, take that dive in. So we think that some of the big most critical groups are listed here, starting here, your hospital leadership, board, and medical staff. Those physicians are trusted. Again, there are varying levels of quality and efficacy when it comes to communications and being able to be convincing as a physician. There's some new research that shows that just saying, physicians saying to do something can actually have a net negative impact, but nonetheless, people are trusting those physicians and those nurses. And I think the farther we get past COVID and you'll start to see some of that come back online. Retracting and not engaging with your community out of that fear is not what we would consider a best practice. And I would say this more specifically, it also doesn't fall within the realm of what we're tasked with as leaders in engaging our community. As leaders, it is part of should be at the top of our job responsibilities, although not listed. It is inherent. And in conveying high quality information that people can trust. They are looking to the people that you hire. And so figuring out how best to empower their voices is critical.
Now I'll give just a specific example. We have a Texas rural hospital client who's their chief medical director is also elected to their local school board. So he's got an amplified role already, a leadership role already on the school board. So he's not only does he have visibility and respect and kind of an authority figure in the community, he's also now going to be part of making purchasing decisions on behalf of the school district. And so having him briefed in and engaged and collaborating with hospital leadership on the problems of Medicare Advantage, while it may seem tangential to what a school board does, it actually is incredibly important because he's got that visibility and that role and that authority.
That's a good point. The hospital board is made up of business leaders from throughout the community. Many of them are trusted on different beyond just their role on your board. They're also seen as people that have civic insight and are tuned in. Many boards have religious leaders, and so them being able to communicate with their parishioners, again, if not in a directive sort of way to give advice on Medicare or Medicare Advantage plans, nonetheless to instill trust in you as a community of healthcare providers is critical. The next one is on your own hospital leadership. I mean, you've got department directors, them having a little bit of insight on the challenges that you face with the financials is significant. And then your nurses. Still, despite a little bit of a hit and decrease in engagement through the COVID months, still have a high degree of trust and influence as one of the top trusted fields of industry in the country. So again, a slight tick down, but nonetheless, nurses still among those who are influential. So when we think about when we are talking about these particular groups, we're not talking about them necessarily just going out and making presentations to civic groups like the Lions Club or the Kiwanis Club or like a United Way. We're also talking about them just standing on the sidelines at soccer games with their kids, with other parents. We're talking about them in the line at daycare doing pickup. We're talking about them at school. We're talking about like what I call the brother-in-law conversations that occur at backyard family barbecues, where, you know, the brother-in-law inevitably asks what you think about this or that and healthcare, because, you know, they're doing a lot of listening to talk radio and their position on something is one way or another. So you're being engaged to get your lay of the land. And so those are critical people to be taking, to be informing, so that they have really important information that they can get out to people and disseminate in interesting ways when we move forward. All right, now then we're going to talk about mobilizing the campaign. We want to, again, as we said, we want to highlight how this are targeting, especially with rural communities, you can really minimize your costs. Talking about targeting into that hyper local market with digital, and then still using some traditional media outlets. So what I want to be clear on, and we can move forward as I kind of talk through this, we're talking about we're not talking about rolling a bunch of broadcast 30-second spots. We're not talking about broadcast radio spots. On radio, you'd be in a little bit more advantageous position because it's a much narrower cast of a radius of your community. But we are talking about some other areas in digital. So your paid Facebook, even some search engine, paid search through Google and or Bing and some other platforms if you choose. But being able to use those digital tools, you can narrow in on just even a set of zip codes or just a respective designated market area that's already set up in each of those platforms. So you can really narrow down your costs. You're not talking about spending $60,000 in a month and having to overlap. So we've got a client that's in the Panhandle. Their major media market is would include a big chunk of Amarillo. There's no reason for them to go spend that $60,000 just to get that small little piece of their community population, you know, 40,000. That's a really expensive way to do it. So what we do is we zero in on their market in each of those digital platforms. And there's a couple other categories there too as well. Again, our other goal here is to establish trust. We want to have some frequency and efficiency. The frequency part of this, we're going to go into some of the advertising and campaign science behind the way humans interact with media and messaging. And then I think we got a couple others on our goals here. And then again, driving audience back to your site for more and more information, and then influencing the influencers so that we can kind of commit those minds who are, some of them may have already made decisions, but we want to move past them and affect those who are affectable. And then more than anything, we got to refine your reputation and work together to keep your position out there, to build confidence in your local hospital, your local practices.
Ultimately, we know the challenge. You know, you've got Joe Namath on your television promoting a particular product. You know, you as the rural hospital, it's not your job to advertise traditional Medicare or Medicare fee-for-service. That is technically the federal government's job. But your job as the rural hospital is to educate eligibles and your community about the advantages of each option. And so that is where digital media is a particularly advantageous platform, because you can have the repetition, you can have the frequency, you can have the targeting, and again, always driving audience back to your website to get that trusted information.
All right, you can move it forward there. All right, so here's where we get into kind of how our campaign model works. And I'll just kind of preface it by saying that we call it our agile communication process. We designed this when we were at the Texas Hospital Association, where we had a lot of complex messages, a lot of complex responsibilities, and we were really putting a ton of work on top of our teams. And so a lot of that work was, we realized was something that we needed to get into repetition. Some of it we needed to get some eyeballs and use as just attention grabbers. So what we realized, and this kind of came online during just after 2012 and the Supreme Court upholding the ACA, was that we knew we would get attention in Texas every single time that we went out and put a press release out that mentioned Medicaid expansion. We knew that we would always get some sort of traction with that. You have a more moderate environment among media. And so we knew that we could always get that. Now, we also knew, however, that while we got that attention from whatever we put out as message, that we needed to do something else to take advantage of that time that we did have with that audience and with that media outlet. And so we started finding ways to get other really critical messages out into the ether while using kind of our position on Medicaid expansion as kind of an icebreaker to run out in front of our main set of message. So we focused in on what do we want to be really sticking in the minds of everyone. We really wanted to be sticking in the minds of everyone on the total uninsured in Texas and the total amount of uncompensated care in Texas. If we get those two things top of mind aware with all media and among the stakeholder community groups across the state, we could ultimately get attention really raised to just how critical that coverage is, despite the fact that all politics that were involved at the time were not going to get us to anything close to a Medicaid expansion. So we devised this kind of what we call our ABC model, or the Agile Communications process. It's designed for that repetition. Once you kind of put a set of A messages out there, then a lot of the B messages are all repeatable with slight variations, but those are the ones you really want to be. The B story is what you want to mention a lot. So we'll go into the A story here. Again, it's unique. It kind of works like episodic television. The best way you can kind of think of it is you sat down in the 80s, especially to watch an episode of Dallas. You know, that's topical reference. And that one episode was about one thing, but there were all sorts of other messages included in the B story that would go out through the season. And then the C story ultimately, like, I don't know, JR's mean. I couldn't think of another C story point. The angle here is that A story might be off of a critical value proposition or something topical or trending that's happening. And we'll have a couple of examples. Well, one example is a patient story.
Yeah, so we've heard from hospitals over and over again some incredibly heartrending stories of patients not getting the care that they need from their Medicare Advantage plan, and the hoops and circles and obstacles that your care teams and case managers have to jump through, or ultimately tell a patient whom they probably know or know their family member, I'm so sorry, we can't get you what we think that you need because your plan won't cover it. So we know that there are stories after story after story. The trick here is then to use that as your A message or your hook, and then transition very quickly to your B story, which is, you know, let's pick 3 things that are wrong with Medicare Advantage: excessive denials, lengthy prior authorization process, and no coverage for swing bed. If those are the 3 things that you identify as the most problematic elements of Medicare Advantage, that's what we want to put on repeat. So your A story can change out with each heartbreaking patient story, but you're going to consistently repeat 1, 2, or 3 of those points you want to stick.
Let's get into the next slide where we go into a little bit about the B stories a little bit more. Sorry, I think this is kind of the way Stephanie just outlined. The localizing some trending topics. Again, we kind of have it blown up here so you can see it a little bit better. You can also break news. I think the best example really is around the A stories with patient stories. But you're ultimately setting up for a B story that you, again, want to get that repetition on.
So, but another A story is if you wanna mix it up and not just have the patient stories, say when open enrollment starts, in whenever that is, in the fall, that can be your A story. We know open enrollment is starting. As you consider which option to enroll, then you go into your B stories. The hospital B stories are the opportunity to then talk about why you think the Medicare Advantage is not best for your patients, or your providers. So you're just looking for a new A story to keep the frequency going.
All right, and so we get into those B stories next here, and I want to make sure that let's see here.
I think the trick is you can't boil the ocean. Like, we all know how complicated healthcare and healthcare financing is. And I think we can be paralyzed by that complexity, and that's what makes this model so compelling. If you think about the A story as being the hook or the angle or the thing that draws a viewer or a listener or a person in to your content, but really refining those B stories of what are the most important things that you want people to remember about the disadvantages of Medicare Advantage. And you can't explain everything in one press release or one op-ed or one digital ad. You do need to have that cadence, but doing that work ahead of time to really identifying, okay, these are the real problems with Medicare Advantage that we see for our hospital, our care teams, and our patients, and then slotting those in where appropriate as you build out your content.
So based on time, we have some time here, so we're going to take apart one of those B messages as an example. Stephanie brought up your swing bed issues, excessive denials, and then some issues like prior auth. So what are we really talking about there when you talk about a patient? You got to take those B stories and put it into terms that are concerning to them. Ultimately, that physician who can't get authorization on that rehab, ultimately that's to the patient's interest, and their concern is that physician doesn't even have total autonomy for what happens to their own patients, and then instead somebody from a call center in, I don't know, North Carolina, I should have found another geography to be more offensive, Oregon, or something that so you have to find that group who you find that message and have it really speak to them, and as some might say, decomplexify just all that is a little bit overwhelming to people, and that is obviously the complexity of healthcare. But
I'm just double down on your points. I think that one about the local versus the kind of call center one is a really important message that does need to be honed and refined and repeated. What Medicare Advantage is now doing is disrupting and contradicting and interfering in this very trusted relationship between a patient and their local provider. And they're basically saying, here, call center person in Oregon or North Carolina or Iowa, who doesn't know this patient at all, doesn't really know who they are, where they come from, their family circumstances. All they have is a piece of paper with a request for a service. They're not taking the time that your physician or your nurse is taking to really understand this person as an individual, their particular circumstances, what their goals are for care, what their family's unique challenges are. So what we're saying basically is that this call center can make a decision about this person's care that is just as good as what the local trusted care professional can do. And I think that's not just personally offensive. I think that needs to really be communicated to people. If you make this choice, this is how your care will be determined and dictated.
Yeah, I don't think that we haven't been able to clearly with a bold enough voice clarify to the market that these decisions are not being made by the physician that you trust, and you guys see that probably more acutely than anyone in a frustrating way. But again, And I think that once those members of Congress start to understand where you are on that and really realize that the difficulty that you're having just for no other reason than to protect the stock value of a for-profit enterprise that is far, far away and on Wall Street. I think the more that they'll resonate and side with where you are on that, especially getting outside of campaign season and fundraising season. We can advance to the next point so we can double down a little bit on some B story. We're sitting here talking about really though on that B message is an idea called perceptual fluency theory. And if you, again, it is campaign season and it's about to get really crazy in campaigns post Labor Day this summer. But if you'll take a look around, and the reason you see so many campaign signs outside is that unfortunately it's what works. And so there's actually some research on this that indicates that just how effective it is, that just seeing a candidate's name can create recall as long as you've seen it enough. So a good way to like really talk about what perceptual fluency theory is my main issue. I got a house full of daughters, so you can imagine my consumption of Taylor Swift is pretty high and not by choice, except now. I think it is probably by choice. I'm not like getting tickets, concert tickets or anything, but I am engaged. And so that first song comes out, I'm not where they are of completely on board. I'm kind of like, it's not tracking with me. It's not resonating. But it's that first time you hear that song, it doesn't necessarily stick with you. But when those top 40 radio stations, that's still a thing, right? Perpetually like keep on playing and playing and playing, it starts to kind of grow on you. That is one aspect of the perceptual fluency theory. The other part of that is that just the ability to recall, and you start to build your own working level of knowledge as though it is your own latently and independently, without the influence. You're not recognizing that influence of an outside stimulus. So we've got the Brainiac nerd definitions there for you, but understanding that B story is really intended to work off of this. And a lot of times you'll see an image associated with a message. That image is supposed to maximize or weaponize your perceptual fluency. So by having that brand or that celebrity associated with your message is to create that immediate recall. I think we all kind of think that we're immune to it. I was trying to think of some ideas where I was not immune to it, and I've actually started consuming a product off of what I've seen. But I remember back pre-Lance Armstrong coming out on getting busted with doping. I think I picked up Michelob Ultra because he was like, had this cool athletic, you're shaking your head. I can admit that now. So that's an example of brand association through a celebrity endorsement. But what we're really talking about, what that really is there is perceptual fluency theory. I'm sure that.
But this is how powerful it is. If all you saw was the swoosh, without thinking, without consciously thinking, I bet you could immediately say Nike and just do it. And those things are so embedded in our head now because of what you're saying, like the image, the association, the perceptual fluency, that's the power of just one very simple little swooshies. That has now driven us to immediately recall, not the Greek god of, being fast, but just do it and the name Nike. So there is a science behind all of this. We're just trying to deal with some, much more complex. So we're not trying to trivialize. I'm not saying we can get to the Nike, level of intimate knowledge, but this is the goal.
Yeah, I think several millions of dollars, and we can get closer to the Nike influence. We can go ahead and advance. We'll talk a little bit about some examples of this as it would be executed in a Medicare Advantage plan. But again, just to double down on some of the ideas with repetition And especially this speaks, I think, to where we are as healthcare leaders. I know that it probably feels like you've talked about these issues till you're blue in the face. And I've talked to a number of healthcare leaders that are just like, I feel like I'm talking to everybody about this all the time. And one of the issues that I think that we have to realize is that our communities are not tied in to every single aspect of what our hospitals are doing every day. What you're doing is very important. You're probably one of the largest employers besides the school district in your community. You may be the largest employer in your community. And so it heightens that like idea that everyone is tied into every single move we're making. But in reality, they're not any more than you're tied into like the local banking competitive market and the differences between one bank or another. My favorite example is like, I have no idea what the Texas Trucking Association is doing, but I bet those guys are working their tails off to make sure everybody knows about the importance of funding roads, the importance of this or that that's in their association advocacy. But once you feel like, oh, maybe I've overstayed my messaging on this, you're like Adam Grant says here, you're probably just getting started, and it's just starting to land. So we've got a couple of books there that are influential, especially for healthcare leaders, that I think are important. A little better kind of self-help than some of the other stuff that's out there. But Adam Grant's a great organizational psychologist that would help across the board. If you haven't picked up any of this stuff, I would encourage you to do so. We can advance. All right, so in some of what that C story message would look like then, it's essentially a call to action. Same concept as in the B story, but essentially we want to have that recall on something that people can take action on. So that's either calling for more information or in this day and age, a repeat of a URL, your domain name, a simple URL, where you can educate people or provide some education, whether it's a place where you have all these articles on Medicare Advantage and how to make your decision, or just your website overall so that they can go there and navigate to get to the information that they're looking for. But ultimately, same idea, get that recall moving.
What makes the C story particularly tricky here is that if you're a Medicare Advantage plan, your C message every time is enroll today. It's that straightforward. It's enroll today. For a hospital, again, because your job is not to say, nor can you if there's challenges with saying enroll in traditional Medicare today, but you can say, talk to your physician about Medicare options. You can say, visit this website for more information. Your C story, your call to action is going to be a little bit softer than the Medicare Advantage plans, which doesn't make it less important or less effective, but you're really trying to drive a message of learn more, educate yourself, talk to your physician about what he or she thinks.
And that educating yourself can be coming to our website to learn more, or talk to one of our physicians to learn more. You can advance through here. All right, so what we're really talking about here is here's some sample content. Now, our A story here is freedom to choose, protect your healthcare freedom. The idea being that you can take your logo and drop it in a place like up in the upper left, move content around if needed. You've got a couple that we would be associating with what that healthcare freedom looks like, health and wellness, outdoors. The other aspect of this, we have some others that are diverse as well. So making sure that you've got diverse content that speaks to multiple audiences is that critical piece of it. But you can see that a message in there where we're talking about, again, catching your attention for protecting your healthcare freedom, and then moving right into your B story that you would have up here multiple times, that healthcare needs can be hard to predict. We basically want to put that idea out there that Medicare Advantage plans may have restrictions that you don't have to worry about right now, but later on when you need that care, it may not be there where you need it. The next B story would be that, and we had a whole series of these where you would still have that protect your healthcare freedom with a new image, but you have that B story, and you would be able to like talk about the that message and talk about your physician maybe not being able to help you get the care you need where you need it. All right, and then you can see our C story message down there at the bottom where it says you can hit that QR code to learn more. Sorry about that. Yeah, you're good. You can move ahead. All right, our next up. So again, we just kind of want to go back over this so you can see it again. That A story you want to hit multiple times in a unique way. And then B, repeat those value propositions. C is a detail with a call to action. I should say that we're not just talking about digital images or blogs necessarily that are your channels. So for these messages or your platforms, we're also talking about these are letters to your editor from your physicians, ghostwritten, developed as a part of your messages, but approved by that physician. Those are really important and really useful tools to influence. We're also talking about letters to your congressional delegation. So if you're in Texas, you're in rural Texas, and want this a letter that talks to your member of Congress about your issues, putting that outline together, or even just using a set of tools, either from Texas A&M's forthcoming campaign or from Torch or from THA, you can depend on those tools as well. And a lot of times they'll already have them ready and turnkey. Again, some of what Texas A&M is developing with us. Trying to think of some other channels that
Even right, again, like local radio, even if you don't have, a local newspaper, you might have a local AM radio that's probably always looking for subjects to interview. If you pitched an interview with that local radio around open enrollment, it's another channel that people do attend to.
right. Want to be respectful of time, but I know we're coming into the last couple set of slides here, so we'll have some time if needed to answer some questions in the chat, or otherwise, if you want to advance, Cassie, I think we have just our contact information here. If you have any questions, hit those QR codes that go to our contact info and then also our website. They're respectively to Stephanie or I. If you want something with some depth and seriousness, I would suggest touching base with Stephanie. If you want some sassy asides and some, Taylor Swift lyrics, I've got some of that. I can send that your way. And then otherwise, happy to answer any questions.
Excellent. Thank you so much, Lance and Stephanie. Let me check the chat, and this is your opportunity. If you have a question, to drop it into the chat box. You can send it to everyone. You can also find my name, Cassidy Avila, and send it to me, and I'll be happy to read it out loud. And I want to say we might have had something, I believe Lance and Stephanie had something come to me. So let me just look. You really addressed this throughout the entire presentation, but this question states, and this came in during registration, so I feel like it's been addressed, but I would love to know more about the ways to share information in writing legally without it sounding like we're pressuring our patients into one or the other.
That is one of the most significant challenges for sure. And I think the lack of very clear guidance puts hospitals in a state of paralysis. Because again, it's the federal government's job to promote traditional Medicare, not your job. But you can educate, and you can certainly share your hospital's experiences. That's not pressuring somebody one way or the other. They can take that information and make whatever decision they want. But that fear, I think, is extremely legitimate. It doesn't invalidate you discussing, your 10 years of experience of trying to navigate working with 10 different MA plans and the 10 different set of policies and the impact that that's had on patients, and give examples 1, 2, and 3. I think it's fair and it's okay to share that information as part of an educational campaign. I think what you can't say, and we're not lawyers, but I think what you can't say is, Anthem's Medicare Advantage plan is the absolute worst and you shouldn't enroll in it and you should pick this instead. I think that's the bright line But I think every hospital has to kind of figure out its own comfort level on how far to push towards that. But, you know, we certainly recognize that challenge, and so our goal is educational versus do this.
It's one of the reasons that the patient narrative is really important. It's that you're giving a real experience that is not really contestable. But again, you're putting that story out there. You're allowing that person to make a judgment of their own. Again, without giving a recommendation. So it's the best kind of education of this person's experience yielded this. This is where we are as providers. We weren't able to do this. We wanted to do this. And ultimately, that's a really great way to do that communication.
So when you're talking to patients, you know, you sort of talk in the aggregate about, you know, here's the differences. Here's how your local hospital and your local clinic is treated differently by traditional Medicare versus a Medicare Advantage plan. If you're talking to media or to a member of Congress or another individual, then the responsibility is on them to get the other side of the story. So we worked with a hospital, I can't remember where he was, somewhere in Texas, and he had, again, just a horrific patient story. And ultimately the patient ended up dying. And while with no definitive statement could we say that this patient died because the MA plan made a certain decision, you could certainly lay out the story and say there were a series of decisions made by the MA plan that delayed, hindered, and ultimately denied the care that was recommended by his local physician. And in a letter to his member of Congress, we did say that he was enrolled in this specific plan. And I think that is fine, and then the obligation is on the congressional staffer to then call that plan and say, we've heard this story, what is your take on it? And that's not gonna get you into that deleterious state that I think, again, we wanna be aware of.
Yeah, and what's interesting about that story, it was Denver City, right outside of Seminole in West Texas. So you're talking about the heart of the reddest part of the country. And these are really critical areas to get into and communicate, not that others aren't as well, given those experiences would be synchronized in other markets. But nonetheless, that member of Congress actually is on is chair of finance. So that's a really important member to be touching base with, to highlight that a constituent has had this experience, and those staffers and that member of Congress takes that kind of thing very, very seriously. And they will make that call. They will do their due diligence on that.
Excellent. Thank you both. I don't have any other questions in the chat. You still have a couple of minutes if you want to drop a question in the chat. I'm going to launch a 3-question poll just to help us with future webinars, if you have a moment to take that. And while you're doing that or typing your questions into the chat, Melissa Lackey, our program director, she had dropped a note in the chat earlier about halfway through the presentation about an opportunity following this webinar that we are collaborating with Groundswell on, and we are opening that technical assistance opportunity up to 30 hospitals or clinics in the state of Texas. There is no cost to participate in this program. All of our technical assistance is at no cost to Texas clinics and hospitals. But basically, you would be walking through the campaign that Lance and Stephanie just laid out. So, you know, it would be consultative services on Medicare education, campaign content, digital and print formats, to just kind of educate your soon-to-be Medicare eligibles or current Medicare enrollees. And if you are interested in that opportunity, she has also linked the inquiry form in one of her posts. And so if you just click that highlighted link, that will take you straight to, it's like 6 or 7, maybe 8 questions to tell us a little bit about you and what you're interested in. Just make note that you're interested in the Medicare Advantage campaign, and we will reach out to you, one of our technical assistance coordinators, and follow up and get you some more information on the campaign and how we might be able to support you.
Yeah, thanks for mentioning that. That's an exciting project, and I know that a lot of those hospitals that have participated in some similar projects that we've we've run statewide have had a lot of success. So we're looking forward to building that out for everyone and freshening up all of that messaging so you can get that out there and affect your communities.
Yeah, we're excited about that. Okay, any final thoughts? I don't see any other questions. Just the one. So you guys did a great job.
Hey, thanks a lot. We appreciate the opportunity. Again, as I said earlier, communicating with your community and engaging them as a part of a critical aspect of your leadership and the privilege that we have of getting to share our voices. I know we take that seriously and getting to talk to all of you today. We really appreciate it. Thanks so much, Cassidy.
Thank you both. Thanks everyone for being with us, and we look forward to seeing you on our webinar again next month. Bye-bye.
Enjoy.
I